My name is Russell Pachynski. I'm an assistant professor in the Division of Oncology here at Washington University School of Medicine in St. Louis. I treat genitourinary malignancies, mostly focusing on prostate cancer and immunotherapy. My lab focuses on generally leukocyte trafficking, but prostate cancer models, tumor immunology, and then some translational aspects. Being immune compromised means that on some level, your immune system is not working completely normally. This can be evidenced a number of different ways. There's generally kind of a cellular part of your immune system and a humoral part or antibody part, and there are various aspects of both of those that can be dysfunctional. From a patient perspective, it means that you are higher risk for infections. And so the majority of cancer patients are immune compromised. In fact, when the immune system in part controls cancer, and so we see increased incidence of cancer in patients with compromised immune systems. Additionally, the cancer itself can and does do a lot of different things that suppress immune responses, and that's one of the ways cancer grows and spreads, is by doing a number of different things to suppress immune responses and to evade the immune system. And so even if you're not on chemotherapy, or your white blood cell count is normal, if you have active, be it metastatic or local cancer, you're likely immune compromised to some degree. So, and again, that puts you at higher risk for getting infections. I mean, it kind of relates to the being immune compromised. Certainly, with a compromised immune system, again, you're at higher risk for infections, for getting infections and having those infections get out of control. I think the data coming out specifically looking at COVID-19 cases is still being analyzed. I know there was some data that came out recently looking at COVID-19 patients with cancer. I think it's probably too early to say what the outcomes are with respect to patients who are COVID positive, if they have cancer or not. Certainly in the US, those, since we're behind in terms of the COVID curve, I think we probably don't know yet exactly what that means. If you have COVID, what are your outcomes going to be if you're a cancer patient versus not? We know that even in non-cancer patients, the response to the virus can be overwhelming, and we see this with other viruses and other infections, where the immune response is so robust that is actually what ends up causing complications and ultimately death. So again, I think it's a little too early to say what that means. In general, however, patients with cancer tend to have, again, their immune systems are suppressed, and they tend to be on, a lot of them on active treatment. So that, of course, could affect how things play out. And in general, cancer patients, especially in prostate cancer, which I treat, these patients tend to be older. And so if you look at the mortality risk from COVID, certainly as you get older, that mortality risk increases. So certainly, these patients are going to be at higher risk for complications. there are a number of different types of oral cancer therapies. There are oral cytotoxic chemotherapies. There are oral targeted therapies. There are now a number of in clinical trials, a number of oral immune therapies. And so it really depends on exactly what type of oral therapy a patient's on. Some of these, especially the targeted therapies, tend to have less general immune suppression with respect to decreasing your immune cell count. Certainly, oral cytotoxic chemotherapies can decrease your immune cell count or your white blood cell count, and so those may be putting patients at higher risk for getting infections than some of the targeted therapies. So it really just depends on the exact type of oral therapy it is. So, I mean, this is a really important question. I think obviously a very relevant one. There's, I think, risk benefit analysis that has to be done for each person. For example, patients with perhaps localized prostate cancer that need a surgery, a curative surgery, or radiation, for example, depending on the exact risk category or aggressiveness of that prostate cancer, they may not necessarily need to have the treatment right away. And so for some patients, it may be reasonable to postpone their surgery or their treatment by a few weeks or a couple months. And then on the other end of the spectrum, there are absolutely patients that should not delay their treatment. So things like aggressive pancreatic cancer that is spread, or Burkitt's lymphoma. I mean, these are cancers that can progress extremely fast. And so in those scenarios, the risk of getting COVID or an infection obviously can be lessened by mitigation strategies. So wearing a mask, hand washing, distancing, etc. And so in those cases, you weigh the risk of waiting, which is a known entity for some of those, versus the much lower risk of exposure and infection of COVID. And so again, it should be a discussion between patient and their treating oncologist with respect to risk benefit, and if this is something that can be delayed a little bit, or if they need to get started on cancer treatment right away. I mean, in general, yes. The similar type of calculation should come into play, especially as we, hit the peak of infections and hospitalizations, et cetera. And those peaks are occurring at different places in the country. So, for example, here in St. Louis, it's going to be later than it is in New York, and San Francisco and Seattle, for example. So a lot of the scans and imaging and blood tests can be delayed if it's for recurrence and routine monitoring. Again, how long you delay those tests and those scans will be determined by exactly what type of cancer it is, how long ago the treatment was, if someone's in remission, how long they've been in remission. For example, if you've been in remission for 2 years and everything looks good, it may be very safe to delay the scans by a couple months, for example. If you've just finished your cancer treatment and you've had a cancer that's at very high risk for coming back, and you're supposed to get a scan every couple months, then maybe that plays into the calculation. So again, it's going to be a discussion with your oncologist and kind of figuring out the risk benefit of delaying those scans and tests.